Very early in adulthood, like 35 to 40 years old, normal aging, your processing times start to slow down a little bit, but it doesn't impact your normal daily life. Like you're still able to complete the functions for your daily life. By the time someone is 60 or so, they may have difficulty recalling certain events, but they still have the ability to learn new skills and to function in daily life. That's kind of what normal aging looks like.
She blinded me with science. She blinded me
There's a fear that lives quietly in a lot of people's minds, especially as they get older or as they watch someone that they love get older. And it's the fear of losing your memory, losing your sharpness, and losing yourself. And here's the thing, most people don't talk to their doctor about it until something serious has already happened. They notice the signs for years, they make excuses, they hope it's just stress or sleep or getting older, and sometimes it is, but sometimes it isn't. So today on What the Health is Happening, we're going to talk about memory and cognitive decline, what it actually is happening in the brain as we age, what separates normal forgetfulness from something that needs actual medical attention, what conditions look like dementia but aren't, and what you can do about it right now at any age to protect your cognitive health. Because the window to act is wider than most people actually think. And the worst thing that you can do is wait. So this is such an important conversation for everyone. So it's great to be here with you, Dr. V. How are you?
I'm doing good. Thank you, Layla, for that introduction.
Awesome. Of course. Yeah. So like I said, I think this is a really good episode and everyone could benefit from it. So let's just dive right in and get into it. Let's start with the basics. So what actually is memory? There are different types, and I think people are often surprised to learn that memory isn't just one single thing in the brain. I think that most people think about memory as one thing. So it's interesting to learn that that's not how it actually works. So let's dive into that. What are some of the basics?
Yeah, so some of the basics are there's short-term memory. Some people call that working memory. And that is basically the ability to just recall something or recall a series of objects that you were told about a couple of minutes later, 3 to 5 minutes later. Then there's long-term memory. And so long-term memory can be what we call declarative, which is declarative means I can recall facts or events from 20 years ago or 10 years ago. And then there's non-declarative. So non-declarative is like I have motor skills or habits that I remember. So an example of that would be, you haven't ridden a bike for 10 years, but you get back on a bicycle and you actually know how to ride a bicycle. So those are kind of like the different types of memory. And they come from different parts of the brain. Right. So your brain is in different sections, the frontal, temporal, cerebral area. They're all impacting memory.
That's interesting that different parts of the brain control the different types of memory. And the bike example, they say once you ride a bike, you'll always remember, or one of the things or something like that. But but can you walk us through what a normal, healthy cognitive aging process kind of actually looks like? Because I think a lot of people are scared about changes that are completely expected. And even though it's expected, it can still be a little scary while it starts to happen, I think.
Yeah. So very early in adulthood, like 35 to 40 years old, normal aging, you will see that, that your processing times start to slow down just a little bit. But it doesn't impact your normal daily life. Like you're still able to complete the functions that you need to complete for your daily life. By the time someone is 60 or so, or after 60 and up, they may have difficulty recalling certain events. But they still have the ability to learn new skills and to function in daily life. So that's kind of what normal aging looks like.
Absolutely. And I know you said even like around 35, that's even younger than I think most people think. I mean, that's news to me. I always think about memory loss as you're older, but that's pretty young to even start seeing some of those symptoms.
Yeah, it definitely starts early adulthood. Yeah, and some people don't recognize it.
Absolutely. And I feel like people joke all the time. They'll forget little things. They're like, oh, I'm losing my memory. And it's kind of a joke because they think it's funny when it's a joke and they don't think it's like coming or at that point. They think it's something further away, but it turns out it could actually be signs of things earlier on. I always think memory loss like 50, 60. So 35 is young to hear that.
Yeah.
And I think that there's also this term that people are starting to hear more now, referred to as MCI. Actually, it stands for mild cognitive impairment, but I don't know what it is. So what is it and how is it different from normal aging? And also, how is it different from dementia?
Yeah. So mild cognitive impairment is somewhere in between normal aging and dementia. So it's sort of in between the two, right? And it's really important that people actually get diagnosed with MCI or mild cognitive impairment because you want to catch these things early. So, so mild cognitive is what I consider to be an early stage. When a family or a patient is concerned about cognitive impairment, then their physician will do like a mini cognitive or memory impairment screening test. And then if someone fails that, then they'll go through much more significant testing. So there's like a Montreal cognitive assessment test. There's formal neuropsychological testing. There's also lab work and imaging that would be done. There's a lot of reversible causes of cognitive impairment. And so someone won't get diagnosed with mild cognitive impairment unless treatable forms of cognitive impairment have been ruled out or completely treated. So, so then, if that's the case and all of the treatable cases of cognitive decline are ruled out, then someone will get the diagnosis of mild cognitive impairment.
Interesting. And I think also along with memory loss, people think about dementia and Alzheimer's kind of the same, maybe even almost use that interchangeably if you don't know. So it turns out that dementia is actually an umbrella term, but most people interchange them. So what are the different types and how do they differ not only in presentation, but also in progression?
Yeah, so mild cognitive impairment will lead to depression some of the times, but not all the time. So, and then once you actually get the diagnosis of dementia, there are different types of dementia. So if I were to start at the beginning and someone starts with mild cognitive impairment, right, about 15% of those patients will actually develop dementia within 2 years, and about 30% will develop dementia within 5 years, right? Now, the different types of dementia, there is Alzheimer's, which is the most common. And that's why I think sometimes people get dementia kind of confused because Alzheimer's probably is about 40 to 60% of all dementias, right? Then there's vascular dementia, which is related to the blood flow and the blood supply going to the brain. That's about 15% of dementia. And then there's a type of dementia called Lewy body. That's about 4 to 6%. And then there's frontotemporal dementia, which is about 1 to 2% of dementia. So there are different types of dementia.
That's so interesting. I never knew that. I thought dementia was dementia and Alzheimer's was Alzheimer's, but I didn't realize that there were so many different forms of dementia. And I think beyond that, another thing that surprises a lot of people are that some of the conditions that look exactly like dementia are actually reversible. So what are those and how often do they get missed?
Yeah. So, well, without proper testing, they can really get missed. What we see most common is someone who has a urinary tract infection or pneumonia or sepsis. We sort of saw it also with obviously COVID. You can see it with the flu. An infectious reason for an infection can actually cause someone to actually begin to have dementia. And then when the infection is treated, they get antibiotics, the urinary tract infection goes away, the sepsis goes away, the confusion then goes away, right? So that's what we would call sort of like a reversible type of dementia or cognitive decline. You can also see it with a low functioning thyroid, hypothyroidism. You can see it with nutritional deficits like B12, folate deficiencies. We can see it with depression. The other thing, if a person is having problems with cognitive impairment, is they'll go over their medications. There's some medications that have side effects, and the side effects of the medication are that it can cause problems with your cognition. And then the other things are like sleep apnea, alcohol, also syphilis. Syphilis has a neurosyphilis component to it. So there's a lot of things that can cause a reversible type of cognitive decline.
Well, I would have never thought that some of those things could affect or contribute to cognitive decline. That's actually wild to hear. And I'm sure you see patients across such a full spectrum while working in the emergency department. So, what brings a patient with memory concerns into the ER? And what are you actually evaluating when they arrive?
Yeah. So usually what it is, someone who's not acting like they normally act. Right. And usually it is something that has occurred that is particularly dangerous. Right. So it could be that they've become combative at home. And maybe the police had to be called. Maybe they went outside, got lost, couldn't get back home. um it's usually something that is fairly dramatic that actually brings them to the emergency department. The majority of patients that sort of experience sort of mild cognitive decline usually go into their primary care doctor and go get it checked out, right? So when we actually deal with it in the emergency department, what we're trying to figure out is, when did this really start, right? Did something sudden happen? What is the timeline? And is this person, a danger to themselves or to others? And then we do a full evaluation and workup, because, they may have a urinary tract infection and have no symptoms at all. If you ask them, are you urinating frequently or burning with urination? They say no, and you check the urine and there's a urinary tract infection, right? So sometimes, they think everything is fine, right? So we really do a thorough workup that involves lab tests, urine analysis, CAT scans, to really find out what is happening. And then if we don't find a reason, we will often admit them, and then they'll see a neurologist and get a full neurologic workup while they're in the hospital.
Let's talk about the Alzheimer's landscape specifically, because I know there's been some real movement in research and treatment over the last few years. So, what has actually changed in that time period?
Yeah, so the original theory with Alzheimer's was that, you had this protein called an amyloid, and it was cut in the wrong place and it got sticky, and then there was inflammation, and it interacted with this thing called a tau protein, and it led to sort of clumps in the cell, and then those clumps actually led to brain cell death. And so we still believe that that is a component of what is actually occurring. But there are other mechanisms also that are leading to dementia, and they're very different depending upon the type of dementia that you actually have, right? And so we're beginning to get a kind of broader picture of how this is actually happening. I think another thing that has changed is there's medications. Before we really didn't have much to offer patients. So now we're seeing different pharmaceutical interventions that people can actually take that will make a difference. And so we're seeing everything from Aricept, which is like a pill, to these anti-amyloid antibodies that are infusions. And so I think we're going to see a lot of growth in the area of treatments for dementia over the next couple of years.
The big role is genetics, or whether it does play a big role or not, I'm not sure, but I know it's something that does come up constantly in these conversations. So, if Alzheimer's, for example, does run in your family, how worried should you be?
Well, Alzheimer's runs in my family. So I am one of those people who is often very worried about it. We have family reunions and family get-togethers, and it feels like, an Alzheimer's convention, you right? And so you can get genetic testing, and I have gotten genetic testing for it. So it's the APO gene, I'm sorry, APOE gene. And it comes in, there's APOE2, APOE3, and APOE4. So basically, APOE2 is protective, right? So people who have two APOE2 genes would then have a lower risk of dementia. APOE3 is neutral, so you would have the average. And then APOE4 is the one where you have a higher risk. So if you have two APOE4 genes, you are 12 times more likely to get Alzheimer's disease. And so it is really something that you can get genetic testing for if you're actually worried about it. I did get genetic testing, and I was really glad that I got it, because my risk is slightly higher, but it's not as high as I thought it was going to be based upon what I was seeing in my family. If you're concerned and it runs in your family, certainly, you should see what category you're in. Yeah, absolutely.
Absolutely. And I think that something that everyone really wants the answer to is what actually works for protecting cognitive health. I think, like we said, it's something you worry about as you get older, and people talk about memory loss a lot, but it's something scary that no one really wants to experience. So, not just the supplements being marketed on social media, but what's the real evidence behind what actually works for protecting your cognitive decline?
Yeah. So yeah, I don't, I think the supplements, it really depends upon which ones you're talking about. Some are worthwhile and some are not. But there's some basic things that actually really make a difference. So number one, physical activity. Whether or not it's just walking or any sort of Pilates. I know pickleball, a lot of people are into. That's one of the biggest things that actually really makes a difference. The other thing that makes a difference is making sure that if you have sleep apnea, that you're treating it, that you're actually getting treatment for your sleep apnea, whether or not, you're on a CPAP machine or any Aspire or any sort of gadget that you're on to really help with your sleep apnea, because sleep makes a really big difference. The other thing that actually makes a really big difference is social connections. So I tell people, get together with your friends for lunch, engage. The more in social connections and the more social engagement you have, the better. There are also some things that people do, like even that have been found to be helpful, like learning a new language. You don't have to become completely fluent in that language, but just the parts of your brain that actually learn new words and learn new things are really, really important to activate. So those are the things that really make a difference.
That's so interesting. Even like that sounds fun, like little things you could do like to learn a new language and things like that. And they say when you do things like that and get your brain flowing, it is good for your cognitive health overall.
Absolutely.
And for someone listening who is either caring for a parent or a family member who may be starting to show signs of cognitive decline, what are some of the most important things that they need to know, and what should they do right now?
Well, I would say the most important thing is to actually go to your primary care doctor. If you feel like things are, getting dangerous, you want to go to the emergency department. But the main thing is, I see a lot of elderly patients and they go to the physician by themselves. It's very hard for someone who's experiencing cognitive impairment to explain what's happening to them. So sometimes it really requires a family member to go to the doctor with them and actually explain what's happening, because someone can observe it more than the person who's experiencing it can explain it. So I think that's really the most important thing. Go to the doctor with your loved one and actually really explain to them what's really going on, and get the screening and see if something is there or not.
That makes sense. If you're the person that's experiencing memory loss, it's going to be hard for you to realize what's actually happening, not remembering, or not noticing. So it's a lot more, I think, evident for someone who's experiencing you going through that than yourself. So that makes a lot of sense. And it's probably a little bit tricky and difficult for people witnessing it as well. It's kind of good to be able to know these things. And I would imagine, and I experienced this a little bit too, because I took care of my grandfather. It's, witnessing someone that you love or care about start to show signs of cognitive decline. It's concerning. So it's great to be able to have someone help you in those scenarios, because like we touched on, if you're the one experiencing the memory loss or any kind of cognitive decline, you're likely not aware of what's going on. In the early stages, it sounds like you will be, but if it's getting more significant or severe, then it's probably hard, like you said, to explain what's going on if you don't really remember, really understand what's happening. And I think this is such a good episode in terms of everyone needs to know this, right? Everyone thinks about this, like we touched on earlier. Everyone kind of fears it, even though it's somewhat expected. You think it's going to happen, but it's good to be mindful of it before it gets there. And definitely, it sounds like there's easy ways to really take care of your cognitive health overall. And memory is identity. It's how we really know who we are, who we love, and where we've been. And the science is telling us something important. The choices you make decades before any symptoms appear are the ones that matter most. So this is not a hopeless conversation at all. The brain has a remarkable capacity to adapt, compensate, and in some cases recover. But it needs you to show up for it with sleep, with movement, with connection, and with early willingness to ask hard questions early on. And if something feels off for you or for someone you love, please don't wait. I think that's a key takeaway from the show. Get evaluated, push for the full workup, rule out what's reversible before accepting what might not be. So you deserve a doctor who takes that seriously. And if this episode helped you think more clearly about your brain health, share it with someone who needs to hear it. It might be the most important conversation that they have this year. And make sure that you do follow the show so you don't miss what's next. And until then, stay curious, stay clear, and take care of yourselves. Thank you so much, Dr. V. This was so insightful. I cannot wait to talk to you soon. It's always a pleasure, always good information, and we'll talk soon.